Hello, there is so much chatter about misinformation these days. I thought it'd be worthwhile to take a look at some of the issues related to that. Specifically, what's been most interesting is watching over the last 4 or 5 years social media platforms that we all use a lot: Twitter, Facebook, even WhatsApp, all these different platforms that we use to kind of consume information. They've gotten very interested in deciding what is and isn't misinformation. And if you are labeled, if you're a content person that is labeled as somebody who's producing information or maybe amplifying misinformation, then you may be taken off the platform and lose, a significant audience. Um, so, the question is, well, how do these large platforms social media platforms go about doing this? And one of the things that they use they use third-party sites to do this. One of the third-party sites they use is a UK-based organization called Full Fact. Full Fact, it's at fullfact.org. They're a registered charity that works in the United Kingdom, works out of the United Kingdom. They're London-based, and we know that they're used by Facebook and at least Google because that's what their funding shows. Right on their website. In 2020, they have Facebook there. Facebook has funded them, has given them almost £600,000 in 2020 alone to fact check. In 2019, Facebook gave them almost £780,000. The next highest, or a few notches down from that, comes in someone else that you may recognize, Google. Google AI in 2020 paid them £117,000. So there's there's a lot of money going to these third-party fact checkers, so they can label misinformation versus information, and this is really pretty important because it kind of controls what information gets sent out, what information is allowed to go out to be consumed by users. It's particularly interesting because in one particular case, Full Fact did a fact check on myocarditis because after not hearing about myocarditis mentioned in the mass media for decades that I've now been in medicine, suddenly a day doesn't go by that you don't hear about myocarditis because of this controversy related to vaccines and what the rates are in post getting a vaccine versus post getting COVID. And anyhow, it's a complicated matter. It's very challenging actually to go through the papers and try to sort out and give context. And here to my surprise, Full Fact has a whole page on this. So I thought it'd be interesting to go through and see how Full Fact does on their myocarditis fact check, since it's something, as a practicing cardiologist, it's something that I may know a little bit about. Here is the clip that initiated the fact check by Full Fact.
Possibility of myocarditis in addition to pericarditis, and so we actually get BMP, ST2, galectin-3, and high sensitivity troponin. Now, the myocarditis that occurs with the natural infection is usually those sick enough to be in the ICU, and it's a troponin elevation only. It's very different than the myocarditis that we're seeing with the vaccines, which we'll get to. The myocarditis in COVID-19 is mild, it's inconsequential, and it's largely a troponin elevation. I don't want anybody to think that the myocarditis of the natural infection is anything like what we're.
So this is the clip that launched Full Fact's investigation. Full Fact, there are four claims that Full Fact kind of went after and basically rebutted and said were false. The first one was that Dr. Mccullough, who's a cardiologist, of actually a very well-credentialed a cardiologist who has a massive number of publications for really not just cardiologists but for anyone who does research. Dr. Mccullough basically said that myocarditis acquired after a COVID-19 vaccination is more dangerous than that acquired after a COVID infection. And Full Fact said that this was false. And I just want to go through this a little bit to explain just how difficult this is. I mean, this requires a tremendous amount of context that I don't think Full Fact is providing you. So Full Fact, in order to support their rebuttal of Dr. McCullough's claim about COVID myocarditis being worse than vaccine myocarditis, has a few paragraphs of text with some hyperlinks to some referenced articles. The first link goes to a CDC Morbidity and Mortality Weekly Report that compared myocarditis rates between those who had COVID and those who did not. And this is a little bit of a separate issue. This particular paper was used to arrive at a very impressive statistic. Those infected with COVID had 16 times the rate of those that did not have COVID. Interestingly, Full Fact doesn't spend any time discussing that top-line conclusion from this study, which would seem to, argue against what Peter Mccullough is saying. In Full Fact's little report, they say, they cite this study as only suggesting that the rates of myocarditis in both vaccinated in those infected with COVID versus those not infected with COVID are very different. Now, just a quick word, a little segue about this particular study, because that's an impressive statistic, right? 16 times the rate of myocarditis seen in those infected with COVID versus those not infected with COVID. This was actually a statistic that was trumpeted by CNN medical correspondent Sanjay Gupta when he came on the Joe Rogan show. Sanjay Gupta is a neurosurgeon in Atlanta, I believe, who's also the chief. I think he's one of the chief CNN medical correspondents and is always on. So investigating that claim, and I've done this on a little Twitter thread when this all happened. The math is pretty simple. You look at myocarditis diagnosed divided by people with COVID, right? That gives you the rate of myocarditis in the people with COVID, and then you take the myocarditis diagnosed in the people who didn't have COVID, and that gives you the rate of myocarditis in people that didn't have COVID. And so when you divide those two numbers, that's what give you 16 times myocarditis in those with COVID versus those that didn't have COVID. But how does one go about getting those denominators? It's really important to figure that out, right? Denominators are super important when you're trying to figure out rates of things. In this particular case, people with COVID, who had COVID, was based on anyone who received a diagnosis of COVID in an encounter with the health system, meaning they were test positive, and that positive test was reported to an electronic medical record that a large health system uses. If you had a positive home test, or that positive test in an urgent care or other facility that isn't part of the health system being studied, out of luck. You'd be in the no COVID bucket. Of course, that doesn't even count. This isn't even accounting for the massive number of folks that are either asymptomatic or mildly symptomatic that don't even bother to get a test. There's also a population of folks that are highly symptomatic and just sit at home and don't test either, right? So that's why most of the time when you're trying to figure out what percentage of the population that you're looking at had COVID or not, you don't just use COVID positive tests, you use some measure of seroprevalence by checking for antibodies. Now again, nothing is perfect. This is all an estimate because you can't really figure out what number of people got COVID to an N of 1. There's always going to be some error there. That's not really the case with vaccinations. You can be much, much, much more clear about the denominator of the number of people being vaccinated because you're running around giving out the vaccinations. You know how many people are being vaccinated. So if you just look at a table from the study, this one particular row, in the less than 16-year-old group, there were 86 myocarditis cases diagnosed out of 64,898 patients who did not have COVID. That's a rate of 1 out of 754. That compares to a rate of 132 out of 3.6 million. So that's a myocarditis rate that's 36 times that for those that are infected with COVID. If you just divide those two rates, but those denominators, that denominator specifically for the COVID infected, who they said was infected with COVID in this large population of 3.6 million, is clearly an undercount. We can actually estimate how far off they may be using seroprevalence data from the CDC. Testing for antibodies in a population sample, again, as I said before, generally accepted as a way of gauging prevalence of disease in a population. That's exactly what the CDC did in a separate report in Mississippi. The Mississippi CDC study estimated a 10% prevalence in people less than 18 years old in Mississippi between May and September of 2020. The CDC paper on myocarditis that I'm talking about right now covers March to January of 2021. That's 6 more months, right? So one was from May to September 2020, right? That's around 4 months or something like that. This now goes from March to January of 2021. So that's many more months. So if you assume a minimum of 10% prevalence, this is an underestimate since the CDC myocarditis report covers, two times the amount of the two x the amount of the Mississippi study. So you'd expect the longer you go, the more percentage of the population gets infected. So in this population of 3.6 million kids that were less than 16, that comes to 360,000 as a denominator. All right, not 64,898 as they got. So assuming just a very conservative estimate of what the prevalence of um, of um, of COVID was in that population, just 10%, right? You get 360,000, which is almost five times the rate that these folks are saying actually were infected in the population. And then again, that's totally believable because 64,898 out of this massive population, those are the folks that were test positive. Not everyone. That does not comprise the entire population that had COVID. So again, the numerator would change as well, of course, but that 1 in 754 estimate for rates of myocarditis in folks that had COVID, that is a wild overestimate. Another way of checking these CDC numbers would be see if the without myocarditis rates, so these folks they did in folks that did not have COVID, what was the myocarditis rate there? That rate should be similar to what the rate of myocarditis was in a pre-COVID era, right? Well, in the pre-COVID era, the rate of myocarditis was anywhere from 0.25 to 2 per 100,000. The rate that they're getting here is multiples of that. It's 4 per 100,000. So, it's a much higher than expected number. So this is not, you cannot use this paper. Full Fact actually didn't use this paper to say this. I don't know why they didn't, because it would seem like the CDC is supporting the claim that COVID myocarditis is happening a lot more often than vaccine myocarditis. And certainly this paper doesn't speak to vaccines, but it speaks to the risk of having COVID myocarditis, right? And in this particular paper, it does not suggest necessarily, based on going through the numbers, it certainly doesn't seem to be the case that COVID myocarditis is happening at these, significant rates. Um, Full Facts goes on and then starts talking about a recent study. This recent study was done by a UK group in Oxford, and it was published in Nature. And this study found that there was an increase in risk of myocarditis within a week of receiving the first dose of both the adenovirus and the mRNA vaccines. It was a higher increased risk after the second dose of the mRNA vaccines. But the same paper also concluded, in quotes, that in the same population there was a greater risk of myocarditis following SARS-CoV-2 infection. Here is the figure. Here's the figure from the paper, though, right? So go to the paper. I looked, go to the paper, read the paper. This is the Nature paper. Most people who follow myocarditis have read this paper, and this is the figure from that paper. And if you look at the table all the way, the chart all the way on the left that looks at myocarditis, you'll see that the SARS-CoV-2 positive test, that's the kind of the orangish red bar. I should say just the red bar. That seems to kind of overwhelm all the myocarditis that's seen after the vaccines. But an interesting thing happens. That's in the general population. That's everyone, right? If you just look at less than 40, okay? If you look at just the less than 40 group, it's pretty obvious that even here, this is again from the paper that Full Facts is quoting, right? Full Facts again said that in this paper, rates of myocarditis are higher after SARS-CoV-2 than it is after vaccination, right? And that in the paper, it may be true in the general population, but even in the paper, and I'm going to talk about a problem with this, it's not true in the less than 40 population. All right. So when you go to less than 40, suddenly the rate of myocarditis after the second dose of the Moderna vaccine, that's what this little table is, bar is higher than that after the SARS-CoV-2 positive test. They did not stratify this by sex, importantly, all right? It's very important you stratify this by sex because males have a significantly higher rate of myocarditis versus females. Again, it's like combining the rate of breast cancer in men and women and giving you a number. like that means next to nothing when you're talking about, say, the risk of vaccination so a risk of a therapeutic in men versus women. When you need to understand the risk of breast cancer in men versus women, right? You wouldn't want to come up with a yearly screening mammogram program for men based on the average rate of breast cancer seen if you take men and women combined. Um, so, so if you're seeing an analysis of myocarditis rates and it's not broken down by age and sex, then this is not, it's kind of a silly analysis. Um, the other problem here is with the rate of SARS-CoV-2 induced myocarditis, SARS-CoV-2 induced myocarditis. The same problem applies. We know the denominator for vaccines given, but we have to estimate the denominator for people with COVID. The authors are very careful. If you notice on these in this graph here, in these charts here, what they have labeled here is not everyone with COVID. They've labeled SARS-CoV-2 positive test. So if you have a SARS-CoV-2 positive test, what is the rate of having, of having myocarditis? Um, so again, this is very different than everyone who has had COVID. The other major problem that I'll bring up again is that the most common thing happening after the heart of patients admitted to the hospital with acute SARS-CoV-2 is myocardial injury that is now picked up ever more often with high sensitivity troponin assays. So, the myocarditis that is being seen after a SARS-CoV-2 infection is mostly is the vast majority of it is related to patients that are very sick in critical care units, who are leaking cardiac enzymes as a result of being overall very, very sick. As a every cardiologist who works in hospitals, who works in critical care units, has seen this, right? Patients are tremendously ill for a variety of different reasons, and as part of their overall primary illness, the heart gets impacted. We even have a name for it. It's called we have a category for it. We call a type 2 MI, a type 2 heart attack. This is a heart attack that we think relates to a imbalance in supply and demand, where because the patient is very sick and the blood pressure is very low or the oxygen levels are very low, parts of the heart muscle aren't getting the blood flow and the nutrients that it needs, and so small parts, you may have a necrosis of cells, cardiac cells, and so you have these leak of these enzymes that are seen. This is incredibly common in the critical care units in very sick patients. A 2013 meta-analysis found that the prevalence of myocardial injury in critically ill patients with sepsis may be as high as 61%. This paper is from 2013, and it predates the introduction of even higher sensitivity troponin assays. So if you redid the same analysis, I can pretty much guarantee that you're talking about 80% and higher rates of myocardial injury that is seen. I think it's important to understand that that is what is being labeled as myocarditis in these post SARS-CoV-2 infections. Now, the hard part here is that we know that anyone that leaks enzymes in a critical care unit, cardiac enzymes in a critical care unit that has cardiac cell necrosis, we know that their prognosis is worse than somebody who doesn't have who doesn't have cardiac cell necrosis. So yes, in some ways, that's the one little quibble that you can take with Dr. Mccullough's statement, is that if you're leaking cardiac enzymes in the ICU, that automatically identifies you as a group of folks that is going to do worse. Generally speaking, this is this is a substrate that is more ill to begin with, and sicker as well. So in that sense, it's certainly correct that not being in the intensive care unit, leaking these cardiac enzymes, that is the primary goal. And so, the best thing for these patients is to not become critically ill. And yes, the best way for this group of patients to avoid going into the ICU. And the group of patients I'm talking about who end up in the ICU are who? They're folks that are, again, the vast majority of them are older and have lots and lots of comorbidities. They have underlying coronary disease to begin with. They've had heart attacks. They've had stents. They've had bypass surgery. They have underlying lung disease. They have underlying kidney disease. So that group of patients that are the highest risk and make up most of the critically ill septic patients in the ICU, yes, that group of patients, you know, should should get vaccinated to prevent them from going into the intensive care unit, so that they then don't leak cardiac enzymes. They don't have this cardiac muscle damage that happens. And again, I got to say, because just to ward off what some people may say by listening to this, I don't want to minimize the relative risk of COVID even to the young and healthy. This is a new virus that's circulating. It's probably more dangerous to the average person than any other virus that you're likely to come into contact with, unless you're, an aid worker that goes and works in Ebola every summer, goes and work in Ebola endemic areas every summer. But the age gradient of this is of risk here with COVID is extreme and should be part of the conversation. So I think it's confusing to talk about the vaccines reducing myocarditis risk from COVID. They do in an indirect way, though. That's what we should understand. You know, this is only if we conflate myocardial injury with myocarditis. Myocarditis is usually considered a separate disease entity, which usually requires a pathological biopsy that shows, not only myocardial cell necrosis on a biopsy specimen of the heart, but also a bunch of inflammatory cells around it. Right? That's how we typically have run around diagnosing myocarditis. More recently, there have been diagnoses of myocarditis made just based on imaging alone, and it saves doing a biopsy. But this is a very, very different patient population that we as cardiologists generally have thought of in terms of myocarditis. We generally don't call the type of injury that's seen to the heart in critically ill patients. We generally don't call that myocarditis. Myocarditis usually was considered to be a separate entity. So, as another analogy, it would be like me saying COVID causes renal failure, COVID causes kidney failure, and vaccines, prevent kidney failure from COVID. This brings to mind a virus that attacks the kidneys and a vaccine that protects against this. I don't think that's the right way to think about it. Severely ill people in the ICU are at high risk of developing kidney failure. Keep them out of the ICU and prevent kidney failure. Keep them out of the ICU and prevent heart damage as well. So take the folks that are most at risk of going to the ICU, and give them, and get them therapies, whatever they are, to prevent that from happening. So of course that means vaccinations, and of course that means monoclonal antibodies. That means Paxlovid. There's a bunch of different therapies now that we want to give these folks to keep them out of the ICU. And yes, all of those things should be on the table. So this data should prompt us to double and triple down on encouraging those that are high risk and have comorbidities to get vaccinated, so that they avoid becoming severely ill. So I think what everyone really wants to know is, does SARS-CoV-2, the virus that causes COVID, does it specifically infect the heart? And I think that data is, it's pretty clear that that is not happening in any significant way. Early on, or I shouldn't say early on, in the fall or so of 2020, there was a bunch of imaging reports. There was some imaging centers that did MRIs on patients that had recovered from COVID, in athletes and other folks, and found that a bunch of them had abnormal MRIs. So there was some consternation at the time about, oh my goodness, is SARS-CoV-2 affecting the heart, and then over the long term causing these cardiac MRIs to be abnormal. But here's the thing: the cardiac MRI abnormalities that were seen were very, very mild, and there's a significant amount of overlap between mild and normal that can be seen with those specific cardiac MRIs. The issue was that there was no actual control group there to see. The control group would be to see, okay, suppose somebody had a significant flu, how many of those folks suppose somebody had a flu and recovered, how many of those folks would have, a cardiac MRI that had these abnormalities seen? You can't diagnose myocarditis with a cardiac MRI only, right? Typically, patients come in, they have chest pain, they have a cardiac enzyme leak, they have EKG changes, and then in that group of folks, you take a look and see with a cardiac MRI whether there's some, scar formation or over the long term, or inflammation in the short term. There, if you see MRI abnormalities in that clinical context, that is a much stronger case to make for myocarditis. So and that's not what really has been seen. The other thing is, okay, fine. Why don't we look to see if there's evidence of SARS-CoV-2, or actually evidence pathologically, via biopsy or on autopsy, of the classic signs for myocarditis related to SARS-CoV-2. Again, in order to diagnose myocarditis, you typically needed to see evidence of myocardial cell necrosis. You need to recover the virus itself, and then you also need to see this classic immune response of the body's immune cells kind of attacking the cells of the heart muscle, kind of causing that necrosis and stuff as well. And that's not what's seen. There was that combination of infection, immune response, and damaged cardiac myocytes has not been frequent. There was one report where a substantial amount of virus was found in 16 of 39 autopsied hearts. So 16 of 39 autopsied hearts, only 16 of them, virus was recovered. But although 15 of them, there was some evidence of some genes, some pro-inflammatory genes that were turned on, none of them had immune cells on autopsy specimens that were indicative of myocarditis. So, I think it's really it's incredibly unclear. There's no evidence, I would say, to suggest that SARS-CoV-2 has some strong predilection for infecting the heart muscle. So going back to Full Facts continues on its rebuttal of Dr. Mccullough's claim, and notes that and links to a Israeli paper that is from August that suggested myocarditis was more common in patients after SARS-CoV-2 infection than after the vaccines. This analysis, again, doesn't provide an age-stratified analysis. So you click on the link and it opens up a paper by Barta et al. In the New England Journal of Medicine, again from Israel. And there's no age-and-sex stratified analysis. It's looking at myocarditis rates seen 42 days after the first vaccination. And so, again, it may not have been enough of a window after the second vaccination to see rates of myocarditis that happened. But either way, forgetting all that, without doing some 10-minute dive into that Israeli paper, what isn't mentioned in Full Fact is that 1 month later, in the same journal, the New England Journal of Medicine, from the same country, Israel, there was another paper looking specifically at rates of vaccine myocarditis, and this is by Mevorak and colleagues. And here, the rate of myocarditis is stratified by sex and by age, and is noted to be significantly higher in young men. The vaccine myocarditis rates are noted to be significantly higher in young men related to unvaccinated, folks with myocarditis. So, it's not small. It's 9 times that risk. This is not mentioned in the Full Fact analysis, right? In regard to Full Fact's verdict, which is evidence actually shows you're at greater risk of myocarditis after COVID-19 infection, and may experience worse clinical outcomes. No, if by the definitions that we used to use for myocarditis, COVID does not cause myocarditis at higher rates than vaccines do, especially in young boys. There isn't that much evidence for COVID infecting the hearts. The myocardial inflammation injury that you're seeing after COVID is probably something that you would see after any novel virus that puts large numbers of people into the intensive care unit. By the definitions that we used to use of what myocarditis was, that Full Fact statement isn't correct. We don't, this is not myocarditis. that we're seeing after SARS-CoV-2. We're seeing myocardial injury, myocardial inflammation in critically ill people who are very, very, very sick. Yes, and yes, if you vaccinate these folks that are most likely to end up in the intensive care unit, you will reduce their chances of ending up in the intensive care unit. So that's how I think we should frame it in a more honest way. The other claim that's apparently made by Dr. Mccullough, again, I haven't watched the whole interview that Dr. McCullough has. I'll rely on full facts for this. Hopefully, they're getting the claim right. But the claim made is that what he said was that the risks of myocarditis in children after vaccinations are more serious and more prominent than post-COVID. Full facts verdict is that the evidence actually suggests the risk of myocarditis is higher following COVID-19 infection, and the clinical infections may be worse. So full fact starts by citing a preprint that was the basis for a presentation by the CDC to the VRB PAC panel, the panel that advises on vaccines, and it's an article by Patel, Oster, and colleagues. And this is how Fairfax presents their findings. They say that one piece of preprint research has compared the clinical outcomes in children with classic viral myocarditis to those with myocarditis linked to an inflammatory condition seen in some children after COVID-19 infection and myocarditis linked to vaccines. Out of 201 patients, 43 had classic myocarditis, 149 had myocarditis linked to the inflammatory condition, and 9 had COVID-19 vaccine-acquired myocarditis. The researchers found that compared with classic viral patients, those with myocarditis linked to the inflammatory condition experienced more significant instances of blood disorders and worse inflammation than when first seen by clinicians. Patients diagnosed with myocarditis linked to the inflammatory condition or vaccination both showed prompt recovery from symptoms and improvement of cardiac function. Well, all right, let's go read the actual study. So the study looks at 3 time intervals to examine 3 different types of myocarditis: classic viral myocarditis and MISC myocarditis. Classic viral myocarditis, MISC myocarditis, and vaccine-related myocarditis. Classic myocarditis, that was looked at from 2015 to 2019. MISC was March 20 to February 2021. Vaccine myocarditis was May 2021 to June of 2021. So importantly, and you only know this if you were listening to Dr. Matthew Oster, present this data to the vaccine safety panel, there is no COVID myocarditis data presented from the tertiary care hospital he was located at because there was no COVID myocarditis that was ever diagnosed.
This is actually performed my role at Children's Healthcare of Atlanta, where I supervised one of our cardiology fellows to look at what was our single center experience with the different types of myocarditis. We did not include acute COVID-19 myocarditis because we really hardly had any cases.
And interestingly, as part of the data that Dr. Oster is presenting at this panel meeting, again, none of this is on full fact. As part of this data Dr. Oster was presenting, he presented 2 large hospital systems that had given him data. And the vast majority of myocarditis seen in hospitalized children with COVID is actually MISC myocarditis. So of all pediatric inpatient admissions that tested positive for COVID across 2 large health systems, myocarditis happened rarely, but myocarditis-related acute COVID-19 occurred 0.02% and 0.08% of the time. Myocarditis-related MISC, which is thought to be an autoimmune condition that happens well after COVID resolves, is what is causing the diagnosis of myocarditis in these children. This is really important because of another slide Dr. Oster showed in his presentation. When it comes to level of myocardial injury, the best measure of this is what I've mentioned before, the enzymes that leak from the heart, from heart tissue when the heart tissue is damaged. It's something called troponin. The higher the troponin, the worse the heart damage, and generally the worse prognosis is long term. When we compare troponin levels in children who had classic myocarditis pre-pandemic to MISC and vaccine myocarditis, it becomes pretty clear that all myocarditis definitely is not the same. There's no question classic myocarditis is associated with is the worst of the 3 by far. There's a significantly higher troponin release in that case. But look how inconsequential MISC myocarditis is when we look at the comparative troponin levels. The box plot is particularly small relative to the other 2 entities because there's a lot more MISC myocarditis. But importantly, it all clusters at levels that barely register. This low level really begs the question if myocarditis is being diagnosed based on these tiny, minimally elevated troponin levels being drawn in very sick children admitted to critical care units. Does that sound familiar to what I've been talking about? The troponin elevations in patients that are critically ill. I was talking about this in the adult population, right? If we check troponins in every single critically ill patient in an era before the new generation, the new fifth generation troponin assays. If we checked it in an older era, that prevalence was 61% of patients with sepsis would have a positive troponin. Okay, that doesn't mean they all have myocarditis. That means they're having myocardial damage from their primary really sick illness, right? It really begs the question when we're talking about MISC myocarditis, given the troponin leak seen here is tiny, is this the same thing that's happening in these very sick children from MISC that are in the unit? That's this autoimmune, shock-like syndrome that happens that kids are very ill with, but there's some minimal damage based on enzyme leak alone. Um, uh, and again, so the thing that partly complicates all of this is that the onset of the COVID pandemic kind of overlays with the advent of these highly sensitive fifth generation troponin assays that are positive, where maybe earlier generation troponin assays may not have been. Not surprisingly, Dr. Oster went on to present data then that showed no persistent cardiac abnormalities on cardiac MRI in children 3 to 6 months after their diagnosis of MISC. Right? So we go on and on and on, and you hear lots and lots of talk, and Full Facts is full of this about, oh, the myocarditis seen after vaccines is mild and no big deal and nothing happens, right? But when you compare it, when you look at MISC myocarditis, right? MISC myocarditis has no cardiac abnormalities seen on MRI imaging 3 to 6 months later. In contrast, vaccine myocarditis appears worse than MIC myocarditis. Troponin levels are clearly higher, and cardiac MRIs are abnormal in a third of patients who ended up getting an MRI to follow up. There's another study released in December 2021 that assessed 140 episodes of confirmed or probable myocarditis following vaccination among adolescents and young adults. It found 19% of patients were sent to the intensive care. None, however, died or required ECMO, which is this massive life support where you artificially take over heart lung function. The study eventually concluded that most cases of suspected COVID vaccine myocarditis occurring in people under 21 have a mild clinical course with rapid resolution of symptoms. Reading the study, it's not incredibly reassuring to hear that 20% of cases of vaccine myocarditis required admission to the ICU, and 76% of cases had evidence of late gadolinium enhancement, which typically is suggestive of irreversible scarring and fibrosis. Remember, these are not MRI findings in completely asymptomatic patients who had recovered from COVID, like I was talking about earlier, that these research done by imaging centers. These are patients that presented with chest pain, the perfectly healthy young people that presented with chest pain after a vaccine. A positive MRI finding in this population is far more likely to represent a real finding in terms of actual abnormality that may have, some type of prognostic implications in the future. These are not, incidental, irrelevant findings that are picked up by, academic imaging research centers that are running around, randomly imaging the general population. Facts for All then cites a popular preprint that finds COVID myocarditis in young men is 6 times more common than vaccine myocarditis rates. And this is the paper that poor Joe Rogan found while live Googling myocarditis rates in young men from COVID and vax, when he was in a little bit of a disagreement with Josh Zepps, who's an Australian media personality that he had on his show. There are a couple of important points in the study. The actual myocarditis rate found using an ICD-10 diagnosis only. Again, all they did was they ran a search on the ICD-10 diagnosis code of myocarditis. That's it. And they popped up some stuff, right? But what they found was 6 out of 6,846 patients. The authors then used some assumptions of how widespread COVID was at the time, derived an estimate of COVID myocarditis of 450 per million in young males. Now, there are about 25 million 12 to 17-year-olds in the U.S. If we conservatively assume that 40% of children in that age group had COVID between April of 2020 and March of 2021, this would predict about 4,500 cases of COVID myocarditis over that same time frame. Recall, Dr. Oster, who's at a very busy quaternary care institution, did a pediatric institution and did research. He did not have one case of COVID myocarditis he could point to at his quaternary care hospital. That's why the comparison group in those 3 things, remember, it was MISC myocarditis, vaccine myocarditis. It was classic myocarditis. There was no COVID myocarditis to compare this to. So they had to go find classic, the typical viral myocarditis that happened pre-pandemic, and then and use that as a basis for comparing risk. So it would be a mistake to say classic myocarditis is the same as COVID myocarditis. It is not. That is not what that Dr. Oster's study did to come up that they could not find any COVID myocarditis. And remember, the two other large hospital systems that were presented by Dr. Oster with hundreds of thousands of pediatric inpatient admissions had a total of 400 cases of myocarditis. The vast majority were MISC and not related to acute COVID. So the number that Josh Zepps is quoting on Rogan, 450 per million, are fantastically enough to have no basis in reality. I mean, there would have been a deluge of cases, and this would have been reported somewhere. And again, don't take my word for it. There's an interview by Dr. Sarah Ross, Chief of Pediatric Critical Care at Tufts in Boston, and that interview is more notable for the concern she did not register in June of 2021, right? She noted, you know what she was talking about in that interview? She noted that never in her career having to take care of vaccine complications until now, and expressed concern that our standards, in quotes, our standards for safety seems to be different for all other vaccines we oppose children to, end quote. The only article I could find written about the massive quaternary care children's hospital in Philadelphia, CHOP, which is one of the best in the world, was about a hospital busting at the gills in September of 2021 from everything but COVID, RSV, mental health crisis, etc. There's no mention of some tsunami of myocardial injury caused by COVID. So if this preprint that people love quoting about the rates of, how significant the rates of COVID myocarditis are is true, I mean, where are these patients? And again, in this, there are plenty of comments from quotes from worried doctors, but none of the reports mention cardiac injury. So for now, at least, it would appear that SARS-CoV-2 and all its various progeny and variants to date have no particular proclivity for the heart. That doesn't mean it never happens. That means that we are thankful and blessed that it happens incredibly rarely. And so we have a number of different data sets to suggest that rates of myocarditis after vaccines have been higher than they were pre-vaccine. There's a JAMA paper that was used rigorous criteria to figure out who had myocarditis based on you can't just have an ICD-10 code of myocarditis. You had to have supporting imaging data as well as supporting laboratory data, right? Those three things together. And this very nicely showed that there was no spike in incidence of myocarditis until after the vaccines were rolled out early in 2021. There's of course that paper in Nature that even though the SARS-CoV-2 denominator, like who had SARS-CoV-2, that denominator is messed up, which means that rate that's published in the paper of SARS-CoV-2 myocarditis is much higher than what it actually is. Even with that, the rates of myocarditis after the second dose of specifically the Moderna vaccine are higher than rates of SARS-CoV-2 myocarditis. Again, specifically in young men. Again, that's just what the paper is showing. Recent study published in the Journal of American Medical Association based on the CDC review of the VAERS database also confirms rates of myocarditis exceed the expected rates across multiple age and sex strata, with the highest risk after the second vaccination dose in adolescent males aged 12 to 15 years, in adolescent males 16 to 17, and in young men aged 18 to 24. The rates were 70.7 per million, 105 per million, and 52 and 56 per million doses of the Pfizer and the Moderna vaccine. And again, importantly, these study authors, this is again the CDC folks, kind of investigating the VAERS database that the U.S. uses for its vaccine adverse event reporting system. They said that given the high verification rates of rate of reports of myocarditis to the VAERS database, underreporting is likely. So therefore, the actual rates of myocarditis per million doses of vaccines are likely higher than estimated. So it seems pretty clear that there's certain subsets of the population for sure that are at higher rates, that have higher rates of vaccine-related myocarditis than COVID-related myocarditis. It's a larger question about whether or not you want to still go ahead and vaccinate or recommend vaccinations for everyone, because there's other things that play into this. But certainly trying to go fact check this particular thing reviewing the data and then coming up with, oh, it's obvious that COVID myocarditis is much worse than vaccine myocarditis, that is something that is, I think, pretty silly to say. I mean, I think the fact checkers should stick to fact checking whether or not Barack Obama was really born in Kenya or not. I mean, those are the type of fact checks that are easy to say thumbs up, thumbs down. Fact checking cardiologists saying stuff about myocarditis, boy, you better be very, very, very careful. Otherwise, you're going to look incredibly foolish and you're going to destroy your credibility. So I'm sure FullFacts does a lot of maybe great things on other things like, fact checking jade eggs that Gwyneth Paltrow sells. But I would stay away from trying to fact check cardiologists talking about myocarditis, because it certainly can get super complicated and isn't quite amenable to a brief little fact check that you do based on 3 or 4 studies that you see, and then you tell Facebook that, oh no, this is really false, and then Facebook labels a cardiologist talking about myocarditis as misinformation. That seems to be a very bad state of affairs.